Ladies and gentlemen, good morning. It's really a great pleasure to participate in this excellent meeting that puts together these three important entities. And I'm especially happy because I'm one of the fathers of this idea. I strongly believe that ISAKOS, as an international world society, I strongly believe that ISAKOS as an international world society acting as an umbrella, together with FIFA, the most prestigious and strong sports organization in the world, and an important local center, prestigious on football injuries, is a right recipe to do this kind of meeting, and we can see by the attendance that I am right. And I especially congratulate Philippe Landreau, Peter Doug, for this excellent organization, but also Philippe Neret as ISAKOS president and Michel Doug as president of the FIFA medical group. So my task today is to talk about ACL lesions and rotation instability. And the challenge is, how can we do it and control it in football? Those are my disclosures. And this is the place where I work, in Porto. Doesn't work? Yes, the right arrow, it doesn't work. No? Not the left one, not the right one. I want to go forward. This is the place where I work in Porto, in a sports center that is also a FIFA Medical Center of Excellency. The problem in instability in ACL is that we don't know which is responsible for stability on rotation and APA. It's classical to say that anterior medial bundle, it's an important restrains PA translation, and the PL is more important on rotation. But in fact, both bundles act as a unit, and they have different importance in different patients. So we cannot rely completely in this information. We know for several years that if we treat ACL, we are not able to prevent completely osteoarthritis. And if we don't treat ACL injuries, we will have osteoarthritis in the future. But we also know that some patients, even without surgical treatment, can do well and can have enough stability for many sports, and even in some exceptional cases in football. So we need to know why does it happen, what kind of patients we should treat, and what is the control of rotation structure. We know that in reconstructed knees, we are not able to control completely rotation even during walking. This is especially true if we are doing more active exercise on the knee. On the three-dimensional plane, we are not able to give a biomechanical normal function to the knee. And this is even more important in football, where you can see that the rotation and the movement to play football, the rotation plays even a more important role. Regarding this, we need to try to find some explanations to say why do we have some patients with complete rupture of the ACL that doesn't have so much instability, and why others have a strong instability. On the other hand, why in some cases we have partial ruptures with big instability and partial ruptures without any instability. Could the bone morphology be a point? We know from the literature that bone morphology plays a role. Anyway, we studied it in a different way, and we studied the lateral condyle relationship with a tibial plateau. What means that we define the plane surface of the external condyle, and we studied this measurement, the relationship with the tibial plateau. We are going to publish it in the American Journal, and this relationship shows that in some cases, if the flat dimension is bigger than the tibial plateau, the lateral femoral condyle slips more, and has a strong correlation with the lateral pivot shift. So it's a kind of a trochlee of the ACL. Of course, that clinical evaluation is the most important thing to do in ACL injuries. And we need to do it with the Lachman test, the lateral pivot shift, but also testing all around the knee, all the structures that we need to know that are normal. Classically, you can measure it, because what you cannot measure, you cannot correct. So we need more and more to measure this instability on the frontal plane, on the sagittal plane, and rotation plane. We had a KT1000, but there is no rotation measurement, no measurement between femur and tibial, only a global AP measurement. I can move there? Okay, good. So we have all these devices, but they cannot be used on the daily life. So we need more and easier devices to use. And go there. Okay. So we need to restore nature, and we need to restore stability. But the question is, how can we know that the remaining bundle is functioning? How can we test it? Is the probe enough? So we think it is not enough. And we think it's very important to define what is normal laxity, how can we really correct translation and rotation, and more than that, what are the cutoff points? What is the measurement above the one is abnormal and we need to correct? That's why we develop a device that is a polyurethane device that you can put inside MRI and CT scan so that you can do a stress MRI or a stress CT scan. And with this device, you can stress PA, and you can measure in stress the rotation and the translation of the knee. So you measure on the lateral side the distance between the tibial plateau and the femoral condyle. You measure on the medial side the same distance, and you can compare with the normal knee, and you also can add these two values, putting together this measurement, what means global laxity. You do it with compressed air on the back, so it's a non-metallic device you can use without any interference on MRI, and again you can measure the distance between these two structures. You can do it in anterior with external rotation and internal rotation of the foot, and you can do it also posteriorly or posterolateral, posteromedial, to do a 360 degrees of study of the knee, so that you have a good evaluation of global stability of the knee. And you can measure all these distance in MRI, having a full picture of your knee with global instability with internal and external rotation. We published our first paper with 28 cases, complete ACL rupture without any rotation of the foot to start, just PA. And we show a strong correlation of PA translation with KT1000, what was normal, but we also show that lateral pivot shift was strongly correlated with rotation, even without doing any rotation on the foot. And then we study a population where we studied the global laxity, what means that we did internal rotation of the foot and external rotation of the foot. And in this study, we correlate the clinical examination and the KT1000 with the measurements, and there was a significant correlation between global rotation and the pivot shift. And there is a strong correlation between anterior global translation and the Lachman test. And when you compare healthy to injured knees, of course, there is an important correlation between these measurements and the lateral pivot shift and the Lachman. And interestingly, very interesting to show that the most important measurement was the global rotation on the lateral tibial plateau. So when you rotate medially and laterally the knee, and if you measure the rotation of these two stress tests on the lateral plateau, you find the global rotatory laxity. And you find a strong correlation with the lateral pivot shift in injured knee, stress versus non-stressed knee. And again, trying to figure out what is the cutoff point, that it was our main goal, we see that on the medial plateau, if you have a difference of 3.5 millimeters of stressed versus non-stressed injured knee, you can have an important correlation with instability. On the lateral side, 4 millimeters. And if you put together the translation, lateral and medial, you have a cutoff point of 11 millimeters. So more than 11 millimeters putting together the two sides, it's abnormal. And on the lateral tibial plateau, if you have more than 15 millimeters putting together internal rotation and external rotation, you have an abnormal knee. And studying sensitivity and specificity, you see that this global translation or global rotation have the highest values on sensitivity and specificity. So really important to look to the knee on a global perspective on rotation and on translation. And this is very clear in these two images where you see the increase of internal rotation of the lateral plateau and the anti-AP translation. Also interesting to show that this device is very useful to show the shrimp gum effect. What means sometimes you have an image where you see a partial rupture, could be a total rupture of the ACL, but you are not sure, some fibers there, and then you do the stress test. And with the stress test, you clearly see the ACL that shows a part, what means that it's a total rupture. And two very clear examples to show the interest in a positive way and a negative way. 24 years old male, knee torsion during a match, doubtful examination, Lachman 1 to 2 plus, lateral pivot shift 0. So it's a complete or a partial tear. We see on the picture that there is something there. Clearly the ACL has a lesion, but how does it work? And you can see here that there is a lesion of the ACL, but we are not sure about the kind of lesion. So we need to know what is going to happen. And then we test with our device, no stress, medial plateau and lateral plateau, very small translation. And with stress, the lateral plateau goes up to 8 millimeters. What means the difference from stress with no stress is 7 millimeters above the cutoff point, so really unstable knee. And we advise this patient to be submitted to surgery. The patient refused it, and 2 months later, playing football, he twisted the knee again, and he was submitted to an ACL repair, then with medial lesion that was resected because there is a new lesion there. So an interesting case to show the useful of this device. And an opposite case, a report is written in Portuguese, but is said that is complete rupture of the ACL on the report. The patient is 23 years old, football player, Lachman 1-2+, and lateral pivot shift 1+, and he was referred to surgery. Then we tested him. You can see on these planes that you have a lesion of the ACL, but again, doubtful lesion. Some fibers, it seems to be extends the lesion. So it was classified as total rupture. But the point is this patient really unstable? So looking to the MRI 6 months later, we can see that there is some healing on the ACL. And you can see very clearly that there is a big changing on the image of the ACL. So there is some healing. The question is this going to work? Should we rely on this image? Should we allow this player to play football again? Not sure. So we did the stress test with MRI, and we saw only 4 millimeters between side to side on the lateral tibial plateau, and no difference on the medial side, on the medial tibial plateau. So again, this patient still today plays football, no surgery, and no symptoms. And I remembered he had a report with complete lesion of the ACL. So in conclusion, what I would like to tell you, that it's very important to evaluate the combination of global translation on PA and global rotation on the lateral side. Is the way to combine anatomy lesion and functional integrity of the ACL. And with this device, we can have a better picture of it. And in our hands, this device improves the correct indication, especially in partial ruptures, but also in total rupture. It can show you the shrimp gum effect when you have any doubt about ACL, and it can have also a role in prevention. You saw recent papers saying that rotation is, again, a risk to do an ACL rupture. So we need more patients and more studies, but I think is the way to approach these lesions. And because we believe in this concept, we are using it also in other joints and other purpose, in patella and ankle. We have this global portal knee testing device now, testing the patella under stress, medial, laterally, rotation, with interesting findings on painful knee versus non-painful knee. And also we are having our first prototype on ankle to test anterior rotation, inversion, eversion. Thank you for your attention, and welcome to ESCA this year and to ISACOS 2017, of course. Thank you very much.